Good morning. Uh, this is the first paper I'll be discussing. This is maintain trial, very interesting trial. Question that the trial wanted to answer is that we are facing every day now the palbociclib is available in the market and in generic form and it is affordable. So what they wanted to do was, as you see in the preclinical data, there was data that CDK4/6 the anti-proliferative effect of CDK4/6 can reverse quickly on discontinuation. There is a continuation of treatment with neoadjuvant CDK4/6 until surgery results in maintenance of the anti-proliferative effect on breast tumor tissue versus if you stop it a little bit earlier. And abemaciclib has shown a similar result in retrospective study where if they were continued post-progression, it had shown some benefit. So this was the design. It was classical, those patients who were ERPR positive, more than 1%, and they were either post more than one or one line of chemotherapy for metastatic setting. So it was ribociclib plus switch endocrine therapy versus placebo plus switch endocrine therapy. And the endpoint was progression-free survival. If you see the results, there is a significant difference in PFS. If you see the hazard ratio is 0.57 and if you in the randomly assigned patients in the fulvestrant and exemestane, there were two types of patients recruited. Few were already 80% of patients were already on fulvestrant, around 20% were on exemestane. If you see, both the subsets had benefit. In the forest plot, you can see all the subsets are almost benefiting. One point to note is around 86% of patients were on palbociclib before they were shifted to ribociclib. So that is an important point to note in this trial. The author's conclusion was there was a significant PFS benefit for patients with hormone-positive metastatic breast cancer who switched endocrine therapy and received ribociclib compared with placebo. The PFS benefit fulvestrant plus ribociclib was limited to ESR wild-type population. So they also tested in a small percentage of patients the ESR mutation, and only in those who were wild-type, they found that it is working well. So my take will be there is an issue with 86% of patients having only palbociclib in first line. Now that the OS data is matured, so probably if the patient is affordable, ribociclib may be the first choice. Besides, again, a small issue with that maybe in first line, maybe anastrozole or maybe AIs will be preferred first line because of the cost affordability. So in these two situations, the other groups are underrepresented. 20% were only on AIs and around 20% were on ribociclib or abemaciclib before shifting to ribociclib. As you see, in a similar setting, the PACE trial was reported. The similar way, palbociclib was tested in 3 arms. Fulvestrant, palbo plus fulvestrant plus avelumab. And you see that trial failed. So there is for sure palbociclib is not working post-progression. There are two important trials already ongoing. One is Harmonia. That will answer many important things. One is, palbociclib versus ribociclib head-to-head trial. So we are expecting the results very soon. Palmyra is a similar trial like PACE. It will be testing the same things if ribociclib works post-palbociclib. Now, the important thing to note here is probably the results gives an impression that ribociclib is a more effective drug, probably a changing from a palbo to riblo is working here. So we have to see if that happens with abema and ribo also. If you see, this is ESMO, the guideline post-progression from CDK4/6. We're not sure continuation will be an effective option right now, but yes, there is data, and in those patients who are not affordable or who have side effects and if they cannot tolerate other things, other options maybe. This is the second paper. This is a pooled ctDNA analysis of Mona Lisa, all Mona Lisa 2, 3, and 7. That was published in Annals. And it is an exploratory analysis. So ribociclib plus endocrine therapy was assessed in phase 3 monalistica 2, 3 and 7 in advanced breast cancer. Better understanding of genetic alterations in advanced breast cancer may clarify resistance mechanisms. So they wanted to do a pooled ctDNA analysis from all the patients from these 3 trials where the available tissues were available and the quality was adequate. As you can see, for a background, this is monalistica 2, 3 and 7, that is, we all know. But, and the primary endpoint was PFS. So the biomarker that they found out and they correlated with PFS. In the panel they tested, it was 558 gene panel, 68 gene panel was found to be altered in more than 3%. Additional genes they saw was PIK3CA, TP53, CDH1, ESR1 and GATA3. If you see the baseline characteristics in the whole pooled cohort, the baseline characteristics were matched, and it is in both ribociclib and placebo arms. This is the analysis of different biomarkers that they found, and if you see, the important ones are enumerated here. ARBB2, this is MDM2, and these all have a significant hazard ratio of 0.5. You see, RB1 is one very important factor. Another finding they wanted to test was the level of TMB, and they did check if in different quartiles what is the effect of ribociclib in different population. So one thing was that they found was higher TMB was prognostic of worse PFS regardless of treatment. So that is one important part. And with the higher the TMB was, the effect was lesser. So the author's conclusion was it identified biomarkers that may be associated with the response or resistance to ribociclib that could affect future drug development for patients with ABC. These data are hypothesis generating and will be important for future research. What I would take it as that it has implication for future clinical research and practice, including identifications for patients with CDK4/6 inhibitor resistant tumors, identification of RB1 mutations, loss of function, alteration of CDKN2A, B, C, PTEN. All these are very, very, very poor responders. So probably if we can do this NGS at baseline when the patient progresses, when they are eligible for ribociclib, probably at that time we can identify those patients who may not respond to ribociclib. And another very intriguing question that the paper raised was, what about high TMB? Are we looking at pembrolizumab in view of high TMB in these tumors? Can we identify a very bad subset of patients in hormone positive subset that will respond to pembrolizumab? So that is a question that needs to be answered. Thank you.